You well?
Yeah.
Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2,
1.
Well, good morning, everybody, dear audience and dear colleagues in San Francisco. I'm Jens Chapman from the Seattle Science Foundation, and it's a huge honor and pleasure for me to introduce our colleagues from the University of California, San Francisco, to today's topic. The Virtual Spine Journal Club has a phenomenal topic inspired by their suggestions and idea. It's called As a Time for Combined Spine Residency Between Neurosurgery and Orthopedic Surgery. As a poignant introduction, I was supposed to be actually starting this conference today from San Francisco, where there's a think tank meeting hosted by UCSF members, and I couldn't do it because I have to do an urgent case on a burst fracture that was treated by a part-time spine surgeon in a very bad fashion. The patient came to clinic on Wednesday and had significant problems, and we're urgently taking the patient for a complex revision surgery today. So might this patient have had a better care by a dedicated, fully trained spine surgeon who does nothing but spine, or mostly nothing but spine? That's a hypothetical question, but certainly that's been a question on my mind. And I'm very sad that I can't be with my colleagues whose presence I find always very stimulating in person, but the virtual one is not so bad as a second option. I want to again thank Dr. Theologus and his 4 great partners and his 4 fellows to select this topic, and we're in for a stimulating discussion that I hope many of you will participate with in terms of exploring the subject of how can we improve the education and quality of care from spine surgeons with new paradigms, such as combining the efforts of neurosurgery and orthopedic surgery. Without much further ado, after the lengthy intro monologue, which includes an apology to my colleagues at UCSF that I can't be there in person, Dr. Theologus, do you want to take us into the topic that you selected?
Yes, thank you, Jens. And sorry you couldn't join us, but that patient care comes first. And again, thank you for the opportunity to present on your forum. We chose this topic, Is it Time for Spine Residency, for a couple reasons. One is we have a great combination of neurosurgeons, orthopedic surgeons at UCSF. We currently have a neurosurgery who was a resident, now is a fellow with us. And so I thought, this conversation comes up in the OR all the time. I thought, let's just talk about it and review the literature. So today we will have 4 papers, 2 of which were actually by Bob Hart. I think he was a leader of this, or at least led discussions about it 10 years ago. So we'll hopefully resurface some of his thoughts and his findings, and some newer information as well. So we'll first start off by having one of our fellows, Matt Easton, present trends in spine surgery training during neurologic and orthopedic surgery residency, a 10-year analysis of ACGME case log data, and the moderator will be Shane Birch. Take it away, Matt.
Great. Can you guys see my screen?
Yes.
Yeah, so as Dr. Thielo just said, thanks for having us. And the article I'm presenting is Trends in Spine Surgery During Neurological and Orthopedic Surgery Training. This is a 10-year analysis of the ACGME case log data published in JBJS in 2019. So let me see if I can, there we go. So our background in the US, spine surgery training is typically achieved through either a neurological surgery residency or an orthopedic residency, followed by a postgraduate spine fellowship. Prior studies have shown specifically Daniels et al., have shown significant differences in the amount of spine training that these two residencies accomplish, and as well as differences in the level of exposure, the various subcategories, differing spine pathology between the two residencies. There are some pertinent differences, obviously. Neurosurgery residency requires higher minimum case log minimums for spine surgery and is 7 years as opposed to the 5 years in orthopedic surgery residency. So this study really aims to expand upon previous studies by looking at a decade of ACGMA case log data between 2009 and 2018 to examine and compare trends in spine surgery case volumes between the two different residencies. So the methods, the ACGMA case logs for both orthopedic and neurosurgical residents were reviewed between that date range, that decade. The data was reviewed for all reported adult spine procedures as well as pediatric spine procedures. And then the total surgical cases in each of the residencies was also reported on. There is some differences between how orthopedic surgery residencies and neurosurgery residencies categorize spine procedures. And the neurosurgery categories were simplified in 2013. So the authors chose to make direct comparisons between specific categories, specifically total spine procedures, adult versus pediatric procedures, percentage of spine procedures relative to all surgical cases. They also looked at specifically adult instrumented fusions and then decompression only cases. And so our results, this paper has a lot of, I would say, like good graphical representations of the disparity between the case volumes. But you can see here the neurosurgeon case, you can see the line representing the neurosurgery residency and the ortho residency, and you can see that the mean number of procedures is obviously higher in the neurosurgery residency. Additionally, there was a stark decrease in 2013 for the orthopedic surgery for all procedures, which I'll discuss later. And you can see that gap appears to be widening. This is just the total procedure, the total spine procedures compared to all surgical cases. And once again, you can see that the gap with orthopedics, it is a small proportion of total spine procedures. This is the actual graphical representation of the percentage of the overall procedures you do that are spine. And you can see that neurosurgeons are hovering around 35% in terms of their total cases that are spine cases, whereas orthopedic residents, at least in the last 5 years, or the last 5 years of the study, are hovering around 5% of their total cases are spine. This is looking at the change in the mean number of procedures, looking at fusion versus decompression. And you can see that the orthopedic fusion and decompression are about equal, and outside of that drop in 2013 have sort of remained relatively level, whereas in 2012 there is a large increase that has sort of been sustaining for neurosurgery residents in terms of fusion procedures. So that dark blue line is the neurosurgery fusion, instrumented fusion procedures, which has been increasing steadily since 2012. And this last graph is just the kind of bringing it all together. This is just the ratio of the comparing directly neurological versus orthopedic spine surgery procedures. And you can see, at least in 2018, there is, orthopedics, as an orthopedic surgeon, the instrumentation is 8.5 ratio times more neurosurgery procedures compared to orthopedics. So they're instrumenting and fusing more than our residents are. So just to review everything we talked about, there is the average number of spine procedures between the two residencies was statistically significantly different, 433 for neurosurgery residents and only 119 for orthopedic surgery residents. Case volume increased by 25% over the 10-year period, whereas it decreased by 41% for orthopedic surgery residents over that 10-year period. The neurosurgery residents performed 3.6 times more spine procedures on average than orthopedics, and this ratio increased to 6-fold in 2018. And this disparity has been seen across all procedures and is actually even more stark in adult instrumented fusion cases, which is 8.5 fold increase for neurosurgery compared to orthopedic surgeons. Just looking at the total percentages, I sort of already talked about 6% versus 33. And this percentage is actually decreasing, though really, really slightly over the decade for the neurosurgery residents. And then there's that stark increase in adult instrumented fusion for the neurosurgery residents, whereas the orthopedic residents had a decrease. Both declined for decompression only, both specialties saw a decline. And although orthopedic residents did perform in total more pediatric spine cases, this difference was not statistically significant. So this is so conclusions of the study, there's a large and increasing discrepancy in case volume of spine surgery procedures between orthopedic and neurosurgical residencies. Although you cannot capture the depth of knowledge solely by case volume, I think that this is a good, I and the authors think this is a relatively good proxy to assess how residents are trained and how they are provided opportunities to develop their spine surgery and clinical skills throughout their residency training. And realistically, an orthopedic residency really should be seen as an introduction to the foundations of spine surgery in preparation for fellowship training. It should not be considered as adequate, I think, for the vast majority of orthopedic residents to do good spine surgery with just an orthopedic residency. And then, they do discuss that typically during a orthopedic spine fellowship, the trainee performs 300 to 500 spine cases, which, closes that gap between the neurosurgical colleagues. Some limitations: this is self-reported case log data, cannot be confirmed as accurate, though I think in general it is relatively accurate. And there is a lack of granularity in the data. We're just looking at kind of broad categories: total spine procedures, fusions, decompressions. There is differences between orthopedic and neurosurgical spine case categories, which can and does make the accuracy of comparing across the two specialties somewhat difficult. But I think that the authors did a relatively good job of capturing sort of the global trends between the two subspecialties. And then, in terms of, what we really want to do is not just have a bunch of people do a bunch of cases, but have them have, high quality instruction and a high level of, surgical skill development and autonomy. And case logs do not represent that, but they do, it is a proxy for that. In terms of discussion, obviously with this topic, we have to ask ourselves, should the model for orthopedic spine training and neurosurgery spine training change? They propose a model for orthopedic spine surgery that is similar to plastic surgery, where a junior resident after 2 or 3 years branches off into potentially a separate spine residency. I do think that one thing I think is that you have to maybe compare the orthopedic spine case volume between someone going into a spine fellowship versus maybe the average orthopedic surgeon or orthopedic resident. For example, my colleagues going into sports medicine were doing everything they could to not scrub into spine cases, whereas I'm sure that a lot of the orthopedic spine fellows this year are trying to get into as many spine cases as they can. I know from my experience, I certainly had more than 60 spine cases in my residency. So I think an interesting study would be to look at just the specific subset of orthopedic spine fellows, how many spine cases they had going into fellowship. I think that would be an interesting study. And then I think it's also interesting to discuss, do orthopedic trained post-fellowship and neurosurgical trained spine surgeons have different strengths and weaknesses? Like, are there advantages to orthopedic training for 5 years? Obviously, I think there are probably pros and cons to both residencies, and you sort of develop different skill sets. So I think that's worth discussing. And then there was a stark drop of orthopedic case volume in 2013, between 2013 to 2012. The authors talk about resident work hours. I pulled up this is from the ABOS and the ACMG, and the orthopedic logging system changed in 2013, where you were only recording one CPT code per case as a primary code. I suspect that this is the reason why the orthopedic case volume dropped so much in 2013. Not like maybe there could be some work hour requirements, but I think this makes more sense. And specifically for spine cases, if you're doing complex deformities, it takes a lot of extra effort to maybe log each of those parts of the case as a separate CPD code in a case. And I think for the vast majority of orthopedic residents, they're just going to put in like posterior instrumentation fusion as one case code. And that's all that's going to get picked up as the primary case code in the ACGME logs. So just something I think to me, that's an explanation for why there was such a steep drop in the orthopedic case volume in 2013. And that's all I got.
Wow. Way to start, Dr. Easton.
Thanks.
Dr. Theologus?
Yeah, we put it first to just put out the major issue at hand, which is that there's very significant discrepancies in training, at least on the residency side. In follow-up, in fellowship, many orthopedic residents do spine fellowships and they get quite a number more cases. I think ultimately it evens out. However, I think many neurosurgery residents are now doing fellowships, and so they're coming out even further ahead. There is significant discrepancy, I think, in the training of within each institution. There are some neurosurgery programs that are probably more heavily brain, more heavily spine, some that are probably more focused on non-deformity cases where others are more deformity. So I think this is not very granular data, but it does demonstrate the huge discrepancy. And I think if you dug deeper into the data, you'd see even greater discrepancy even within the individual field. So it is, in my opinion, a need to, we ultimately need to not standardize our care, but I think improve quality and efficiency. And to do so, we need to have a more standardized way of training the people who go into the specialty.
Can I make a comment? So first of all, this is a great way to start things off. And this shows the power and the value of a journal club. I knew of this article back when it came out. Obviously, it's been much discussed. But I think like 6 years later, I'm seeing new angles of this presented by different colleagues. So this is, again, underscores to me the value of a journal club. So there are things in this article that I had just forgotten or had not emphasized enough. So I really appreciate that. For me, the angles are severalfold. Number one, our specialties have very different political interests. Orthopedics has, however you want to define it, roughly 8 subspecialties. And when I was at UW, a third of our cases were spine cases. We had a very busy integrated spine service between neurosurgery and orthopedic surgeon. We wanted it that way. But our residents complained that there were way too many spine cases. And we tried to make it worth their while. But a third of their cases were spine. And in orthopedics, roughly 1/10 of the cases, 1/8 or 1/10 of the cases are supposed to be spine. Spine is not a popular subspecialty, not just in terms of the avocation of the residents, but also politically within our organized bodies. I used to be in a leadership structure both in AAOS and AOA. And again, I was the token spine surgeon in there. It was kind of really weird. And it was not a liked specialty. We operate too much, we earn too much. That was basically the premise. So politically, the double ANS, when I needed help in our state, I've always had great support from organized neurosurgery. I did not have the same from AAOS and AOA. So I'm not asking a good question here right now, but Dr. Eaton, what is your summary? If you're a future leader in spine surgery, what would you say? Orthopedic surgeons have to do a spine fellowship, right? But are we not making it cool enough, or should orthopedic surgeons do a better job trying to have an organized approach towards spine surgery, be more of a focus of their training? What's your thought?
Yeah, I mean, obviously I'm biased because I wish I had a residency where 1/3 of my spine cases, 1/3 of my total cases were spine. But I mean, in talking to talking to other residents across the country, and certainly my co-residents during residency, in general, people just don't like doing spine cases. I think because they're long. I mean, they're sort of different than the average orthopedic case, especially like the more complex ones. You're in the OR for 8 hours, or a long time. As you said, you do. Spine cases go, at least at my institution, the latest case is the latest orthopedic case is the spine cases every day. Those are the cases that get out the latest. So I think that a lot of the residents who are, to their defense, aren't going to be doing spine, through their lives in their practices, don't really enjoy doing that. I don't know what it is a bit. There is a problem in the sense that, like, yeah, if 90% of the people in a specialty are doing something that they just don't like doing, like, that doesn't really make sense to force it upon them. I do think there are values to having a strong spine, particularly a strong spine clinical exam for the average orthopedic surgeon. And I think there are values of having a strong musculoskeletal physical exam for the average neurosurgeon. But I think for a lot of my colleagues, like the operative techniques of decompression and stuff like that, for a sports medicine doc, he's not as interested in that. And I don't know if I have a great solution.
We'll continue this discussion shortly. Let's move on to our second paper out of the sake of time. This is going to be presented by Anu Botbold. She is one of the neurosurgeons. She's a fellow, her residency at University of Chicago, and she's joining us this year. And then the moderator will be Nima Allen, who's one of my neurosurgery colleagues. So we're going to get a little bit of the neurosurgery flavor now. Go ahead, Anya.
Hi, everybody. It is my pleasure to be here discussing this article, which actually, thanks to Matt for building it up really nicely onto my topic. And this is more of a survey, essentially answering some of the questions that we just raised up about how people feel about the basic structures of the residencies and case logs and time spent. It's not necessarily like an evaluation, but more of like a picture of what it looks like for both groups training these people. The background, like Matt mentioned, we do have ortho and neurosurgery, which have different content. Ortho requires fellowship, and the basis of this paper was that there was a survey in 2013 essentially doing a very similar things, and they wanted to see if it made, if anything changed essentially over 10 years. At the time in 2013, most people who answered the survey was not completely happy with the way things were. This is a cross-sectional survey from PDs who's either ortho residency or neurosurgery residency or spine fellowship PDs. They sent out 466 of them. 322 was residencies and 144 was fellowship. And the questionnaires was 24 questions for the residency and 40 for the fellowship surveys. And they did a basic chi-square statistical tests. The response rate, they got 94 PDs to reply, 42 fellowship PDs, both ortho and neurosurgery, 28 neurosurgery residency PDs, and 24 ortho residency PDs, and ones who decided to complete the survey, answer to the survey, completed a survey 100%. The first, there were a bunch of different things they went through, and I picked out the most important or more, I guess, the key things that they questioned. The first one was, what does it look like for these residents during their training? And it looks like neurosurgery, most programs, 39% of them spent more than 12 months on a dedicated spine service, versus about 85%, which is majority of the ortho residency, spent anywhere from 2 to 6 months on a dedicated spine service, versus non-dedicated spine rotation, meaning essentially combined with everything else, whatever else that might be doing neurosurgery. 89% of them spent more than 12 months, and 1 to 6 months of ortho residents. 83% of the ortho residents spend 1 to 6 months of non-dedicated spine rotations, and I think it's reflective what Matt was mentioning, just the case volumes differences between the two. Ideal time to spend on a spine service actually differed significantly, and I think it actually is very reflective of the conversation that we had. Both ortho fellowship directors and the neurosurgery fellowship directors, or PDs, think that ortho residents need longer exposure, but the ortho PDs were very happy with way things were. So it doesn't seem like there's a lot of drive from a mass to change that. Case volume wise, I think Matt got into it, so I don't think it's very relevant here. Essentially, neurosurgery has a lot more case logs at the end of the training versus the ortho ones. And the one thing that was unique was that graduation confidence, meaning if they ask the PD if their residents are confident in diagnosis and management, and then management includes surgical management, 100% of the neurosurgery PDs felt comfortable with their residents doing basic spine, versus 58% of the ortho PDs where they thought their residents will be able to clinically manage the spine problems, versus 25% of the residents are actually going to be able to surgically manage them. Fellowship level wise, it seemed like the fellows, either neurosurgery or orthopedic surgery, log very similar volumes. Most of them accept both neurosurgery or ortho graduates, but if they were given a same applicant, one neurosurgery trained, one ortho trained, a lot of them preferred their own specialty. Fellowship experience wise, one thing that was different between two fellowships was that neurosurgery used a lot more navigation versus orthopedic surgery. Otherwise, the MIS and robotic case volumes were very similar between the two. Opinions on training requirements, orthopedic PDs said that, both neurosurgery and orthopedic surgery residents should do fellowship postgraduate, and versus a neurosurgery said only the ortho residents probably absolutely needs fellowship. But one thing they did agree on is regards to deformity surgeries. Essentially, everybody said that, regardless of where you're coming from, you need a fellowship dedicated for these cases. This was actually one of the more interesting slides. I thought that I knew this was probably the case, but I guess it's nice to see an actual number on it. And when they evaluated their residents from, the experience with both specialty graduates, neurosurgery fellows rated higher on surgical skills, confidence, and CSF management versus the ortho fellows rated higher on biomechanics and bone metabolism. And if you see the graphs, it's just essentially like mirror image of each other. They complete what the other one don't feel confident. Satisfaction in training in regards to the models. It seems like overall everybody is just not happy with the way they are, regardless of where they're coming from. Support for dedicated spine residency has increased significantly from 24 to 39. However, it's still not the majority. So yeah, I guess everybody's unhappy, but the push to change that situation seems to be becoming more prominent. However, still not the majority. The limitation of the studies, the true responses unknown. You sent out an email, and also obviously there's a bias because the ones who are responding may have more interest in the topic than ones who are not responding. There's obviously cross-specialty bias because they're answering questions in regards to the other specialty when they're not trained in that way. The fixed response format limits the specific special situations or other nuances that may affect the topic. So the conclusion is that ortho versus neurosurgery spine training remains divergent. Fellowship is essential for deformity cases. Ongoing dissatisfaction with the training model, but support for dedicated spine residency appears to be growing over the last 10 years.
Great, Anna, good job. This is Nima Allen. Few comments building up on what Matt said and what Anu said. Quantity versus quality. It is known that neurosurgeons do more cases, but I will be the devil's advocate that I think doing more cases might sometimes provide a false sense of security for neurosurgeons. And I do think quality of the cases matter. The case in point is purely anecdotal. With my observation, and I think everybody would agree, is that there are a lot of fantastic orthopedic spine surgeons who don't do thousands of cases during residency, but they do high quality cases during their fellowship in a range of 200 to 300, maybe a little bit more, and they are just as good, if not better. So quality does matter. I would even say I would probably wager against that part-time spine surgeon who did this is probably a neurosurgeon because again, devil's advocate for our field, there might be more dabbling than orthopedic surgery. If they don't feel confident, they will probably not take it on. But I don't see the orthopedic side as much as my orthopedic colleagues, but I do see it in neurosurgery. Obviously, I agree about biomechanics and bone metabolism. I try to address that in our neurosurgery residency and fellowship to talk more about that. I got exactly 0 hours of talks about bone metabolism and fusion in my residency and my fellowship. Not exaggerating. So I've said something that I'm paying attention to myself as I'm still like 3 years into my career and learning that. And final thing about spine, it's interesting to me that there's dissatisfaction, but still not a lot of people are supporting having a spine residency. And I was saying before the discussion started, I think the elephant in the room is what are the finances of having a dedicated spine residency for this supposedly newly formed department, and how is that going to affect the other two specialties, taking away substantial amount of revenue, I would say, and case volume from those respective departments. In the 4 papers that we're discussing today, we're not discussing that because nobody's going into that direction. It is politically sensitive topic to go there, and I think our, leaders, more senior colleagues, have the political weight to look into that. But that's what's going to come down to, I think. That is this going to be feasible? And obviously, there's going to be standard amount of resistance to change, as it was the case for plastic surgery, vascular surgery, and whatnot. But yeah, I don't want to take too much time on my monologue, but
Well, Nima, I'm glad you.
yes.
Yeah, I'm glad you brought those points up, and I think they're very relevant. There are things that we have to learn from the orthopedic side that neurosurgeons learn in their residency. About CSF management, about any intradural type of work, the anatomy. Those are the types of things that we have no exposure to. I also agree that the biomechanics and the bone metabolism are one thing, but like Matt said, the musculoskeletal exam, how does a hip OA patient present, knee OA, carpal tunnel, all those things that we get through our residency, I think would benefit the neurosurgeons. I do think that there is some political delicateness here, but many of those subspecialties like vascular, plastics, they all stayed within general surgery. They haven't created their own departments. And I think it would be the first step to, say, at a place like UCSF, 2 strong spine programs, to commit to say, hey, we are going to select 1 or 2 residents per year in each department that will do 3 years of, say, neurosurgery, 3 years, or we're going to talk about this in the last paper, 3 years of neurosurgery, 3 years of orthopedics, and then or come up with some combined program. And then for the last 3 years, so maybe, or last 2 years, 2 to 3 years, 5 to 6 years total, that's going to be the spine residency portion of it. So then you can keep the things separate, which both departments will like, but the training for the residents will be combined, if that makes sense. I don't know.
Yeah. Dr. Theolokis, yeah, it's a great point, and thanks for the reference to vascular surgery and plastic surgery. That's exactly my question. I was going to ask Dr. Alan about that. And Dr. Alan and Nima, I really appreciate the differentiated reflection on quality versus quantity of training. So vascular surgery has done this, and plastic surgery has done this seemingly without any major upsetness. There are various pathways to go into plastic surgery nowadays, but one very established one is 3 years of basic general surgery, and then from different pathways you can enter vascular surgery. Same for plastic surgery. What was so easy for them that we can't duplicate? Is it the fact that it's all under a mothership of general surgery, but many places nowadays actually have separate divisions or departments? So what is different in those 2 specialties that we can't emulate?
I think not separating the finances is important to not create resistance. but if I'm not sure Jens said it was like that easy for them. I remember obviously I was young enough to see only like plastic surgery residency exists as a separate thing, vascular surgery exists as a separate thing. But when Chris Shaffrey gives this talk, he talks about like there was a resistance to adopt this model. But I think that's just a standard amount of resistance to change. Um, and a solution that kind of what Alekos mentioned, I think is something that can be accomplished in certain programs. Uh, I think UCSF is primed to do that. Places like Duke, I think Cleveland Clinic is the ones I'm familiar with. We do have kind of logistics, the numbers and whatnot to do it, but again, there has to be political willingness to do it. And when you look at the surveys, despite the satisfaction, there's still not a lot of people who are saying that we should have a spine residency. That's what's like odd to me, that people are saying that. Yes, it's growing, but it's still a minority. That's what I think ultimately the issue.
We probably should go on to the next one, but I had a question last real quick. On when in your residency, and Nima, same question to you, and maybe to all the fellows, when did you decide to go into spine?
I started thinking about I started neurosurgery thinking about skull base. I started doing spine cases as an intern in Pittsburgh, and basically by the end of my intern year, I wanted to do spine.
Okay.
Yeah.
Mine was more later. I didn't really know if I wanted to specialize. I was more of a general side of it. And then towards the end of my fourth year, which was like the end of my actual spine rotation, I was more confident that that's what I wanted to do, which is quite later than I think most average neurosurgery residents deciding what their specialty is going to be.
Okay. Yeah, I was an intern. I did a neurosurgery case as an intern. I thought spine is the way to go. So,
Exactly.
but I thought I wanted to do sports medicine. So it just shows you when you go into something, you think you want to do something that you can change very quickly. Anyways, that may be a reason why committing to a specific residency from the start may not be the best thing. All right, next one. So we will go on to the third one, which is going to be presented by Mohammed Al Amoudi. He's coming to us from Canada, and Sig Bergen will be the moderator for this one. And Mo, if you can go a little fast, because we have one more after this, that would be helpful. I think this is a small paper anyway, so, but anyways, go ahead.
Can everyone see my screen?
Yes, we can.
Yes.
Okay. So today's topic, good morning, is going to be about graduates of orthopedic residency training and how that is trending towards increasing specialization. It's a review based off of an ABOS Surgery Part 2 database, a retrospective. This has been conducted by Horst et al. So in this paper, the introduction goes over historical analysis, basically from the 1990s to 2006. General orthopedic surgeon has overall been trending down from 44% to 30%. Orthopedic surgery has experienced a significant growing trend towards subspecialization ever since its fellowship first gained popularity in the 70s. The primary aim of the current study is to determine the number, percentages of those who go into fellowship training, and comparing the data from the Part 2 ABOS from 2003 to 2013. So before delving into data, I just wanted to go over the pros and the cons of subspecialization. Pros, it adds additional clinical expertise or academic experience. It's good for securing employment. It's more favorable for practice, lifestyle, and in subspecialty domains, including hip arthroplasty, has been shown several times that having a dedicated fellowship in specific training to it leads to better outcomes, reducing complications as well. So those are pros. Cons shows that smaller community general orthopedic surgeons having a decreasing number leads to an ever so increasing demand. But at the same time, the comfortableness and the confidence of orthopedic surgeons to cover more emergent and open injuries has been very difficult to find coverage for in those smaller communities. And further to that, fragmentation of orthopedic surgeons' specialty has led to fragmentation of care from patients. So they have to seek multiple surgeons as a result. So again, the methods is a retrospective study. They looked at CPT codes. They've excluded those with less than 5 codes per year. It's thought to be a methodological error in their inputting in the system. Secondly, they wanted to divide them based off of fellowship training. So they were divided into 9 categories: sports, hand, shoulder, elbow, recon, spine, pediatrics, trauma, foot and ankle, and trauma and tumor. And since there's no real established definition, the authors took it upon themselves to decide which procedure falls into which fellowship training program. And so they went over the CPT codes to split them into these categories. And then finally, CPT codes outside of one's field was calculated as a percentage of the total procedure of that individual. Overall, there was Overall, there was 1.5 million procedures performed by 7,600 applicants, and that is about 97% of the original number of applicants that they had included in the study. So these are the results of discussions, and you can see on the left chart here that the trend continues to increase, and you can see from 2003, it went from 75% to 90% in 2013, and we are about 12 years from there, so this is probably closer to 100% now. On the right-hand side, you can see that the generalist on the bottom curve here is actually decreasing as well, and it's getting very, very close to a very minuscule number, whereas the number of applicants who are fellowship groups has been trending up in the opposite direction. So not only are there fewer generalists, but also fewer outside of fellowship procedures performed by those surgeons who are fellowship trained. So what I mean by that is the percentage of procedures performed within this fellowship has been increasing from 2003 to 2013. You can see it goes from about 75 to about a little bit over 80%. And on the right side, you can see that the percentage of procedures performed within the specialty is even more high for those in hand and spine, but lower in reconstruction. So not only are there more subspecialization, but also those who are subspecialized are almost exclusively focused on their subspecialty, and that number is even more, it's even higher for the hands and spine training. The one thing I wanted to note in this paper is that while recon was the lowest, about 60%, they're actually the highest in terms of the trend. They've been growing at about 2% per year versus the average of everybody else, about 1% per year. So while it is the lowest, it could potentially overtake the others eventually. So there are several limitations in this study. This is a self-reported study. The other thing is there's no real definitions about what particular procedure a particular surgeon exposed in their fellowship. So they've acknowledged that, and that's how they kind of designed this research study. And the other thing which anecdotally is a bit surprising is the pediatrics specialty is technically one where an individual is kind of delineated by an age cutoff rather than a procedure. So anecdotally, one would expect that percentage to be 100, but that wasn't the case in the study. So in conclusion, at this rate, as you guys observed, orthopedic surgery residents will seek increasingly higher fellowship training, and to a point that might end up being everybody. Performing procedures exclusively within one specialty is increasing, and the concern with this is this might lead to significant workforce gap in the future. So this requires a significant amount of training, and the explanation to why this might be the case, hand, for example, might be because it was the first formal ACGME fellowship. And spine, I think the authors described that this might be related to necessitating greater exposure in the setting of case complexity. So they need to be focused on their field. So thank you for listening to me. That was my presentation.
Mohammed, that's a terrific, important paper. This paper actually came from our colleagues here at UCSF. And I was surprised by some of the numbers here, specifically the percentage of orthopedic graduates doing a fellowship. As you indicated, this has increased significantly over time and probably continues to increase. It's interesting because we were talking earlier about when and why each of us perhaps chose spine as a specialty. And for me, quite honestly, the reason I chose spine is I felt like it was the only thing I really would have needed a fellowship for. I felt very comfortable doing trauma and arthroplasty, foot and ankle, even most of the hand procedures were very comfortable. But spine was one that clearly, especially spinal deformity, required further fellowship training. Now, I have to admit that I'm not comfortable. I would rather have an arthroplasty trained person do a hip than me do it. You know, the anterior approach techniques have evolved, the subspecialization. I think it would be interesting to see how that translates to quality of care. But anecdotally, there's no question that our hand people do a better job on hand and elbow. Our sports people do a better job with ligament reconstructions and arthroplasty than I would do, or that a generalist would do at this time. So I think that there is some value with regard to quality. My concern, as you indicated at the end, is the workforce and in terms of actual access to care. And access to care is a major problem in the U.S., it's a major problem in underserved communities especially, but even more broadly. And I share concern about the type of wait times people are getting and the access that people may have to care when we become so subspecialized. So I think it's a difficult balance. I'm a big supporter of breadth in training. You know, again, I think that the techniques that I learned in peripheral nerve surgery from our hand people, the techniques I used in pelvic surgery from our trauma and pediatric surgeons are indispensable to what I do now. So that exposure, I think, is important. Getting the right balance, I think, is a difficult one. And I think that overall, as we increase subspecialization, it's all the more reason to make sure that we're working communally. You know, one of the great strengths we have at UCSF, I think, is the ortho-neuro partnership, where I've learned so much from my neurosurgery colleagues, and I hope that's been reciprocal. I give the example that I would have never used a burr for a decompression before I started operating with the neurosurgeons, and many of our neurosurgeons would have never used an osteotome to remove bone before they started working with me. So we learn a lot from each other in an ongoing way, and I think that ongoing collaboration is really important, both ortho and neuro, as well as between specialties.
Hey, Dr. Bervin, and first of all, thank you, Dr. Al-Moody, for that very nice, succinct presentation. There have been efforts at trying to create subspecialty certifications, and certainly hand surgery and sports surgery in the ortho realm have been success stories in this regard. So for hands, plastic surgeons and orthopods can get a subspecialty certification. Sports has done this also. Spine has not succeeded with this. So there's been an American Board of Spine Surgery, but there's never been a subspecialty certification, both for ortho and for neurosurgery. Wouldn't this be a very plausible first step to kind of define this subspecialty more and kind of create a minimum standard for entry-level certification?
Mohammed, you want to take a stab at that first? Because I've got some thoughts about that, plus and minus.
Pros, I agree that could potentially be a very good way to get the ball rolling per se, because then it'd be very clear where the specialty starts and where it ends, and where then other fields would require to intervene. Cons, however, is there's a lot of fellowship programs all across the country, both in the U.S. and Canada, and to get them all into to this could potentially slow down the process of developing a combined program. So there's a lot of disagreement, as we saw in the previous studies. So getting people to agree would be the first step. So I think education will come ahead of that.
I think that's a really important question about subspecialty training or subspecialty certification. Is, you know, certification, licensure, these are mechanisms by which there's some restraint of trade. And to that end, if we create a situation whereby You've got to be subspecialty certified to perhaps be able to defend yourself in a lawsuit case, to be able to actually enter into the field. That's a real restraint for a lot of people in a setting where, especially in underserved settings, where maybe generalists are more important. At the same time, I think that there is a certain quality assurance with regard to that. So in terms of if there's concerns about quality of care, there's concerns about people doing the wrong type of procedure or wrong specialty type of procedure, then maybe certification would be necessary. In my hands, I'm more concerned about the restraint of trade and more concerned about restricting access to care than problems with quality right now.
All right, great discussion. I wish we could keep going on that topic. The next, just for the sake of time, we'll move on to the last one. We have about 10 minutes, and this will be presented by one of the neurosurgery fellows this year. He's working with Chris Ames and Aaron Clark, Rahul Sastry, and I'll be the moderator, but I think we'll end this after this presentation with a discussion from the entire group. So go ahead, Rahul.
Hi, and thanks for having me. I'm Rahul, and we're going to be looking at this paper that was written by Dr. Alan Daniels and several of our mutual colleagues in the orthopedic and neurosurgery community. Unlike some of the previous ones, this is actually more of a proposal for how a combined training would look, as Dr. Theologis alluded to earlier. And I think the problem is pretty well elucidated by all my co-fellows who've spoken before me, so we won't have to go through it in quite so much detail. But in general, they identify these current challenges in spine surgery, which is that kind of the need for relevant and field-specific expertise, just like Dr. Bourbon said, has actually increased over time, probably in all subspecialties of both fields. The technologies we use today are quite a bit different than the technologies that were used perhaps when the training models were first invented. And as a result, even spine practice is increasingly subspecialized, where we have people who may specialize in pediatric deformity or adult deformity, tumors, and so on. The authors also assert that spine surgery has a pretty significant PR problem, that quality and outcomes are very variable, and that, at least in the lay media, there is a common and probably true perception that spine surgery, and especially fusion, is overutilized in patients for whom the indications are not particularly clear. For these reasons, the authors feel like the current training model is not designed in a way that really has contemporary practice in mind, and that there's a significant need and opportunity to reform the training model. I think everybody in the audience knows what the current training model is, but I think it suffices to say that it's not very standardized, that the length of training is very different between the two fields, and the things that you see if you're a spine-interested resident, as we all were at some point, in the non-spine components of our training are pretty significant, both in type and volume. There's a significant discrepancy between what we do, and I think that is also really this probably cites the papers that were previously presented, but both in averages and minimums, there's a big difference between what we see in neurosurgery training and what orthopedic residents see in orthopedic training. I think the only additional point, which is probably obvious to everybody as on the call, is that there's a wide intra-program discrepancy. They point out that essentially, if you look at the 90th and 10th percentile logs within each field, there's about a 10x difference in what you might see. Anecdotally, as a neurosurgery resident, having spoken to a lot of other neurosurgery residents and a lot of other training programs, there are definitely some that may do even more spine than what I was exposed to in residency, and some that do a lot less. So we all come at it with different amounts of experience, even within our fields. The authors propose a combined residency with the following potential benefits. They feel that higher volumes necessarily yield better outcomes, that if you're exposed to a greater complexity of surgery, surgeons who will generally have fewer complications regardless of what complexity of surgery they're performing in the future. And that it would result in a really meaningful and pedagogically valuable consolidation of spine-centered curriculum and education. They draw heavily on the experience of vascular surgeons, which essentially exists now as both an integrated residency and like a post-general surgery model. There are residents who kind of come to a career in vascular surgery in both ways. And I think, as was stated previously in the discussion, this has been like a multi-decade long process. That this initially started with a separate board certification process in the 70s, and it became designated as a primary specialty only as recently as 2006. But for those who are unfamiliar, you can match into an integrated model, or you can get there as a postgraduate of a general surgery program, as is the case with plastic surgery. They proposed something kind of similar with a spine surgery residency, in which they would have multiple parallel tracks in which a orthopedic or neurosurgery resident could get to spine surgery as a career in parallel, essentially with an integrated residency over 5 years. The proposed model would, over 5 years, involves like a PGY1 that's pretty similar to at least what we see in neurosurgery, where you spend a lot of time rotating on relevant subspecialties that are of relevance to a general spine surgery practice. You spend a PGY2 year doing rotations in orthopedics and neurosurgery that are non-spine, so maybe you get exposed to cranial neurotrauma or orthopedic joints. And then PGYs 3, 4, and 5 are almost exclusively dedicated to spine surgery, with subspecialization and trauma and degenerative pathology as a PGY3, and then a chief and senior residency experience as a PGY4 and 5. We can go through this in more detail if people want to see it, but this is essentially what is proposed in greater detail. They kind of review some of the challenges associated with the model. I think the first and the biggest one is that it's hard to change the status quo and overcome inertia. Just as perhaps there's not a perceived epidemic of poorly trained surgeons out there in practice, that I think if you ask most surgeons if they were happy with their training, a lot of people think that probably the way that they did it was a good way to do it. I think the financial argument that Dr. Allen alluded to earlier is pretty significant as well. That there's a pretty significant potential loss of revenue from either department, potentially, if spine surgery was separated from it. It's certainly very evident to me in neurosurgery that would be the case. But I think there are good counter arguments that you could implement it as like a division or even an independent training program without necessarily severing the finances. A third point, which I lack a little insight into common community orthopedic practice, but it really has the potential to dilute general neurosurgical call pools and training. There are, for better or for worse, a lot of people, especially perhaps who are practicing and not in urban areas or not in major academic trauma centers, who truly have general practices, who do spine surgery, but also do general cranial neurosurgery as well. Probably at an acceptably high level. And if, it is a potential value that people can do both, because a lot of what we see in cranial neurosurgery are pretty objectively rare pathologies. It would require a formal application to the ACGME and development of new standards. So I would say whatever is created is going to take a while to create. There are already trends towards like significant subspecialization, within our fields that'll probably accelerate those. We need a spine-specific surgery board. And I think the author's most practical, immediate conclusion is that we should develop a committee that should really explore this in detail and make some best practice recommendations about what should happen next, which I think is eminently reasonable. And just to maybe kickstart the discussion, based on what we talked about thus far, to answer Dr. Theologis's question, I decided probably late PGY3, early PGY4, which is exactly in the middle of my neurosurgery training, that I wanted to do spine. But with the way that the fellowship process works through neurosurgery anyway, it's kind of about the right time to apply. And I think a lot of people in a previous generation would say that that's kind of ludicrous that you could pick a subspecialty without even having been exposed to half of neurosurgery. And I think that's probably a fair statement. I think it really would benefit from a good definition of what precisely the problem is. I think there is certainly an educational gap in terms of what we see didactically in our two trainings. But whether or not that translates to, surgeons who are maybe out there in the community feeling like they're uncomfortable doing what they're doing, it's like a little unclear or not borne out by the data that we've seen thus far. There's a lot of logistic challenges, even beyond the finances. If you had like, a separate pool or maybe neurosurgery residents that could opt into like a subspecialty training at the end of their residency, how you kind of get a small neurosurgery residency to cover call across all years would be a bit of a challenge. And I would just say that I really enjoyed my training. Like, I trained at a program that did a lot of spine, where we had a combined conference with orthopedics every week. And I'm in an awesome fellowship where I get to learn a lot from our orthopedic colleagues every day. I think we bring different things to courses there are a lot of ways that people who are interested in spine make up for that differential exposure in their residency. And I think it's perhaps to the benefit of us all. Hand surgery is probably like a good example of people who still train separately, but do each other's fellowships in the field. I think is perhaps really rich as a result of it. So I'll turn it over to the group to talk about it some more.
Thanks, Rahul. We are at time, but I wanted to see if there's any comments on the last paper from Jens. And Sig, I cut you off on a very important discussion on the last paper, so feel free to continue on that, Dane.
So first of all, again, great 4 papers, great selections, great presentations by all 4. Thank you. Quick question to all of you at UCSF. So you're one of the leadership groups in the country or in North America in terms of integrating efforts. If you look at these articles, sorry, they're about 10 years old. What has changed? Have we accomplished anything? I mean, we have a 10-year reflection now. Is there a committee? Is there a forward movement to be integrative, or are we just in the same stalemate as before?
I think there has been improvements, although I wasn't involved in training at that time. But I can say that I do feel, like Rahul just mentioned, that we are starting to have a little bit more cross-pollination with fellowships. More neurosurgeons are doing orthopedic fellowships. I don't see a lot of orthopedic residents doing neurosurgery fellowships. I think that would be a nice option. I do think that certain departments, Duke, you're going to be visiting there, is making an effort towards that, having one quote-unquote leader of both, and whether there are residents that are getting exposed to neurosurgeons during the residency, just in somewhat of an informal setting. So I think there has been good gains, and I hope that we continue to ride the wave. I do think that more programs need to combine it, and I think there needs to be a little bit more formal combined education sessions, conferences, didactics, and surgical opportunities for each group.
Jens, I think your program in Seattle really embodies a terrific combination of ortho and neuro, and I think
that's true.
Example, and I think continuing to get exposure to each, both through fellowship and beyond training. Quite honestly, my exposure was to neurosurgery was much more beyond my fellowship. So paying attention to that throughout your career for the fellows on the program today.
So we're at time. I want to take this opportunity to thank our colleagues at the University of California, San Francisco, who in so many areas have led the way and continue to expand our knowledge field and do it in an integrative fashion. And maybe we can take this as another kickoff point to trying to advance our field forwards in a combined fashion. I'm very sorry that I can't be there today, but as I said earlier, I have to do a mess-up case, and I will send you the results of this case after hopefully a successful conclusion. You'll understand what I'm talking about in a second or later today. But thank you so much for doing this. We really appreciate this, and to be continued. Thank you.
Thank you, Jens.
Thank you.
Good.